So basically, it's all about the patient and the clinically what we see. So we want to be able to examine the patient really well at the first appointment, sounding the bone, pocket depths, looking at the x-ray, root angulation, tissue thickness, biotype, see where the crestal bone levels are. Also, we want to check the patients to see how comfortable they are with what they have. Maybe they're okay with a removable, maybe they want a bridge, so there's a lot of different options. But in general, the standard of care is an implant. If we can place an implant, it's most probably the better option. And also, we have to keep in mind the aesthetics. What's aesthetic for us may not be what's aesthetic for the patient and vice versa.
This slide is very important because today with media, patients are coming in asking you for these procedures. They're going to come there and say, doctor, I want immediate implant placement, not knowing really much about it, the science about it. They're going to come in telling you, I want something, you're going to ask them, why do you want immediate implant placement? They're going to say, well, I want to have more comfort. I want to have improved aesthetics because I've been told with immediate placement there is improved aesthetics. I want better chewing, better phonetics. These are the patient parameters. Don't let the patient, however, dictate treatment.
Patient satisfaction with the aesthetic outcome is key. Fewer surgical interventions and shorter treatment time with immediate implant placement. And we talked about the different times we wait. When I talk about implants and I teach implants, the key number is 4 months, or 4, even 4. So when someone asks me how long does tissue take to heal, on average, rule of thumb numbers, 4 weeks, 4 to 6 weeks, 4. How long does bone take to heal? About 4 months. Okay, so rule of thumbs. Okay, good to know. Even like the sinus membrane, it says tissue. How long does that take if you perforate? 4 to 6 weeks. Okay, so tissue, 4 for weeks, bone 4 months. Now, sometimes you have to wait 6 months or 6 weeks, but that's just an overall number to keep in mind. Now, is overall cost reduced with immediate implants? Probably not. You're still doing the same procedure. You're still temporizing perhaps. You're putting bone graft, membrane. We're not like lawyers that we charge for chair time. So if we have to uncover, we do it. We charge per case. So I would say for us, I don't think we really notice a difference in the cost if we're going to place it immediately. Okay, so this picture is a little bit small, but as far as complications, when you're taking out a tooth, there's a reason why we're taking out the tooth. It's a bad tooth. There's been a bad endo. There's a crack. There's a fracture. There's something going on that this tooth needs to come out. So a lot of times during this extraction, it could be a traumatic extraction. We might have to reduce a little bit of bone to get a purchase for the elevator. We may, as we're removing the tooth, we may remove the buccal bone with it. How many times have you taken out a tooth and you removed a big chunk of the jaw, the bone, the alveolar bone? And also, you have to keep in mind that there's something called bundle bone. It's about 0.4 millimeters thin, and this bone always goes away after you remove a tooth. Also, when you're doing an immediate, again, taking out a tooth, putting in an implant, you have a hole, you don't have a cover, so bacteria could leak inside. You can perforate the buccal plate as you're placing the implant if you have a very steep angle. So with patients who have their anterior teeth flare out, that means that when you're placing the implant, you have to place the implant following that bone so you can perforate. And you can also get dehiscence of the wound. So sometimes the wound doesn't close over. Okay? Especially, I find that if you don't place the implant deep enough, then the gum cannot cover over. Because everything likes to go in an area of least resistance. So as the gum is closing over, if there's any kind of foreign object in the way, it might just stop. and it doesn't like to climb. So you need to always have it going in a downward direction. So placing your implants deeper. And I see a lot of people who do bone grafts, they overfill the bone. Just because your assistant gives you a whole, pours the whole bone, we should always be pouring the bone because they don't know. They just put everything they have in the bottle. We don't want to waste bone. We don't want to waste anything as dentists. We put the bone, we pack it over, and now all of a sudden you have a high, high bone level, and the gum has to climb over this, and so it usually doesn't make it. And if you place a membrane over, okay, so we took out a tooth, we placed the implant, we packed bone graft around the buccal. A lot of times we place a membrane, a resorbable membrane. Okay, again, how long does that last? Your patient's going to ask you, what's a membrane? It's a resorbable collagen that they make it out of different materials, but you place it over. It doesn't allow the soft tissue to come inside and cause a problem with your integration. So everything below turns into bone, everything above stays tissue. Now, what happens if this membrane gets exposed? Thank God the way they design it, not much. As long as you keep it clean, the patient takes antibiotics the first week, rinses with Paradex, we're not going to see too many problems with membranes being exposed. If you have a titanium membrane, yeah, sometimes those can have an issue. But membranes, they're made in a way so that if they're exposed, they're fine. Okay? Let's look at success rates. What's more successful, waiting or placing an implant, and what are the differences? In general, if I were to tell you that out of every 100 patients that you treat, you're going to have 10 patients that are going to have more problems, would you do that procedure? Is that worth it for you, for your practice? 10 more times that patient coming and sitting in your waiting room? 10 more times your assistants are going to say this patient is here again? So we want to be predictable. We don't want to have issues. We want to sleep well at night. We have to look at that number. And you can see that, the percentages are pretty even. With 46 patients in this study, survival rate was, between waiting and not, pretty similar. Now, there's a lot of factors that also come into effect. Does the patient smoke? Are you putting a temporary over it? Is the temporary hitting? How many times have you made a temporary and the temporary is putting pressure on the gum? Whenever you're putting pressure on the gum, blood's not getting to it, the tissue is going to die. So all of these things are take into effect when you look at these numbers. Okay. Also, to keep in mind, as you go to these seminars, you'll hear the word survival rate, success rate. So don't get fooled. Survival means it just is present in their mouth at the time that the patient came back. Success means there's a whole criteria for success. You want to go over the criteria? It's very important.